very briefly, in less than 15 minutes, at the importance of decentralization integrating viral hepatitis services, especially in the context of Africa. I'm sure we are all very familiar with this kind of data and evidence. Just want to highlight that it's when we go beyond just the big numbers of the 17 million people being affected, over almost 800 deaths per day in the African region. The key thing is when you compare to other regions, you notice that when it comes to indices such as diagnostic coverage, Africa is doing 4.2%. If you now take it for the same diagnostic coverage for all people that are supposed to be diagnosed, it's even smaller, 0.2%. And these are all for just hepatitis B. The picture is similar for hep C as well. So we really have to change the narrative, especially in the context of Africa. So how do we do that? And these are very, very strong WHO recommendations, practical recommendations beyond the medications that you give and all of that. The practical recommendations to move us to be able to eliminate viral hepatitis by 2030. These 4 recommendations are very, very critical. The need for us to decentralize healthcare services. Basically, what we mean by that is you move hepatitis care and treatment from the specialist hospitals, from the teaching hospitals, the regional hospitals, right down to the primary healthcare facilities, even to the community level. And whilst doing that, we ensure that we integrate as well. So integration means that you ride or leverage on existing structures of the health system and embed hepatitis into those as well. And then you have to simplify the models and then the community engagement. So today we'll look a bit more into the first 2. So you were picking something? Okay. I'm sure the slides will be shared anyway. Okay. All right. So when we talk of decentralization, as I've already mentioned, it's really the way to go. We cannot continue to have, if you take the case of Ghana, for example, probably less than 20 gastroenterologists. They are all in the 2-3 teaching hospitals across. Even some of the teaching hospitals sometimes will not even have these gastroenterologists. So we cannot provide the care to the millions of people that need it by focusing up in the hierarchy of the health system. The services must go right down to the lowest level. And the evidence for it is very, very clear. This study that is quoted here was done in Uganda on a very small scale, but it showed very clearly that it's cost effective, it's cost cheaper per patient when services are decentralized and integrated. It is safe and it is efficient. So the data and the evidence is abundant. And the HIV narrative is a perfect example that hepatitis, the 2 illnesses are very related in a lot of ways. So if something has worked in the HIV space, it's very easy for us to leverage on that. And we all know in Africa what decentralizing HIV services has enabled us to do over the years. From a death sentence to today, just more or less another chronic illness. And that happened because we moved away from insisting that only physician specialists will be able to manage HIV to say that, look, a well-trained nurse, a well-trained physician assistant, and even now sometimes non-healthcare workers are helping to manage HIV patients at the community level, to the extent of sometimes even initiating people on treatment. Of course, you need to do it in a very structured and systematic way, but it has worked, and this results that we see, including even the sustainability. The HIV response has become sustainable because of this form of decentralization that we talk about. In places where, and that's where the integration comes in very, very important. With the global health crisis that we have currently, where our dearly beloved Donald Trump pulled the plug on all of us and pushed us over the cliff, the countries that had integrated their HIV services, such as Ghana, for example, had very, very minimal impact. Because you go down to the healthcare facilities, HIV is integrated. The nurses that provide HIV services are not different. They are paid by the government. The supply chain system that's being used to provide the ARVs are the same one. It's not a parallel one. The data systems is not a parallel one. It's integrated. So when the plug was pulled, yes, there were shocks here and there, but it was easier to manage because the services were integrated. Unlike other countries where there wasn't integration, the sustainability becomes a huge. So it's very important that we learn these good lessons from the HIV space. Another good example of how decentralization has worked, and this time the example we are using is in the hepatitis space. This particular hepatitis service, infant hepatitis vaccination, is decentralized and integrated with the EPR program across Africa. And that's how come we have 72% coverage for the Hep B, the 3-dose, that's what we call in most countries the pentavalent dose. You realize that it's a hepatitis service, but a lot of people that are routinely in the hepatitis space don't even often realize that it is actually a hepatitis service because it's very decentralized and integrated into the EPI program. The EPI colleagues implement it, run with it, report on it, get the vaccines, the supply chain, everything going. Even in countries where there's no hepatitis program, this service continues to go on, and the African continent is benefiting very, very well from it. Similar is the BEV dose, which is new. We are not doing too well in Africa with that at 17% coverage, but it's feasible and it's doable because, again, the EPR program decentralizes this. The vaccination is not limited to the high-level facilities. It's done right down to the very, very primary community-level facilities. The key challenges when we talk of decentralization, two that I would want to emphasize. When we talk about decentralization and integration, a lot of times it is discussed in the context of limited funding. But when you look at it, the limited funding, it's more of because hepatitis does not have money, we have to integrate. We have to integrate because we don't have money, so we have to leverage on other existing programs. I tend to argue that somehow the reverse is also true. Even for you to integrate and decentralize, you need money. It's called the HIV, the TB program, the malaria program, the EPR program, huge resources to get them to that decentralized and integrated levels that we have. And it's not going to be like the hepatitis program comes to the table with absolutely no resources and says, we want to integrate. A typical example is when we recently, there was in Ghana a proposal to train on triple elimination. And this is a typical triple elimination, hepatitis B, HIV, and syphilis. But because the hepatitis program came to the table with absolutely no resources, the content that you would have in that training for hepatitis B becomes very limited because everybody is bringing some money on board. Everybody is contributing something. You come with a lot of, oh, I'm poor, so help me. It doesn't work. You come to the table, you come to the meeting, you come with some limited resources, and then you have a say at the table. So whilst we talk about decentralizing integration for hepatitis, we need to acknowledge that we still need resources to be able to do that. To train that community health nurse in the CHIPS compound, that physician assistant or that nurse at the remote, even if that person is an HIV person, so has good knowledge of antiretrovirals, you still need some amount of capacity building for that primary healthcare provider. And they are huge numbers. So training and building their capacity would cost us a lot. So we still need the resources. The political will, I wouldn't spend too much time on that. It goes without saying that that is needed, and we need to be very, very strategic. A lot of time when you have the political will, the money follows. And that's what we need for hepatitis to also get the place that it needs at the table. There's one slide that I think I've missed. Maybe I'll spend some time on that before I go on to this one. So basically, if you take the example of Ghana, for example, WHO, GasLaid, and then the Ghana Health Service piloted some decentralization work in 3 facilities recently in the Greater Accra region, the Lekma Hospital, Adabraka Polyclinic, and Mamobi, where some nurses and medical officers were supported, trained. It was just a one-day training, more of an orientation. And then they were provided continuous mentorship by the gastroenterologists like the likes of Dr. Adjoeji and Sally Bampo. And they are being continuously supported to provide this services, treatment, and care for patients that are diagnosed with hepatitis. And the training was very light, but the mentorship is what is key. And it's been a very, very good example of how we can decentralize. So whilst it still requires resources, we can all do it. You are a specialist, you can pick one primary health facility that is near you, give them some capacity, mentor them, and instead of referring every single patient that comes, they just take the results, you ask them, do the profile, they can send it back to you by WhatsApp, and you interpret it and provide remote support for them to be able to provide the needed treatment and care and support for the patient as needed. Another good example is we have, even still in Ghana, is the treatment free treatment for Hep C, where over 20 facilities across the country, primary healthcare facilities, are the ones at the forefront of this treatment. And over 600 patients have been treated over the past 1.5 years through this system. So it's something that is really, really doable. Simple platforms like WhatsApp are used to provide tele support to different healthcare workers across the country when they are struggling. The one barrier you notice for hepatitis treatment, for example, is the interpretation of the profile. Non-specialists struggle to really grasp that. So when you have that support, it's something that makes a big difference. And these opportunities leverage all of this. And again, the AI presentation that we just had comes in very, very well. There's this opportunity for just AI on phones to be used. Basic apps are available, actually, that can be used to support non-physician specialists or non-specialists to be able to interpret hepatitis profile results. And that small support can make a huge change in the quality of service that is provided to clients, so that clients do not need to travel miles to specialist centers. The service rather is provided to them at their doorstep, and that's the whole concept of decentralization. So this is where the kind of situation that we have as we speak now, but this is the picture on the other side is where we need to be going, where hepatitis is integrated and a part of the health system. And in fact, so we get to the point where those barriers that we have, those white lines themselves, as you can see in this picture, we've started dissolving them. They dissolve completely so that the patient is the center of the services that we provide. And every service that the patient needs is brought to the doorstep of the patient. We need to support decentralization of viral hepatitis services. It's really, really the only way to go. And we need to leverage the existing systems to be able to achieve it. Thank you.